Okay, this chapter will be on end-of-life care. Okay, we really have to look at, historically what influences and attitudes towards death, looking at older adults and their families as we plan for it, looking at cures, hospice, and palliative care, the goals of each, what is our role at the end of life, and this is very much an interdisciplinary team approach. We're going to look at some basics of fundamentals of pain management. We're going to look at contemporary death in a multicultural society. So really this is where culture comes so into play, with religion and culture and end of life and spirituality and how do people grieve and mourn. We have to really take care of that caregiver and look at that compassion, fatigue, and role strain. We have a lot of legal and ethical issues, and how do we summarize what's a good death? So we've got a lot of key terms in this one as well, and some good studies, and I hope you all have your advanced directives filled out. So the thing is, it's a circle of life, unfortunately, many people die after what we call that prolonged illness. It's usually not a trauma, but more prolonged, which does allow people um, time to get their wishes out, use different options, but it also leads to a lot of role strain on that family. And we've got to be very aware of that. And usually it's the person that's accepting, but it's the family that's having a hard time. As nurses, it is usually for us to bring up the idea of hospice or palliative care and look for those directions, how we can get other people involved to assist them. In our communities, we have extremely active hospice and palliative care. It doesn't matter what hospital you're at, whether you're Marshfield, Wausau, Wisconsin's very progressive in that area. We still, unfortunately, though, have a denying society. I think that, Disney had it right when they did The Lion King. We celebrate the circle of life in this society. I think we've got it all backwards. We celebrate these little babies coming into the world and buy them all kinds of gifts they don't need. We want to hug them and we want to babysit and we want to take care of them. But the problem is that isn't what happens when people are aging. We kind of neglect our elders. Prior to World War II, you lived with your elders. It's not seen anymore. We're very single dwelling, and that's really changed. So, but that's kind of changing again, coming back to where our elders are starting to live with us. When we're talking, it is difficult. It's very hard, and it takes a while to get to that place where you're comfortable about it. I worked hospice 10 years. I felt it was my calling. It was never difficult for me, but it was also in the way I was brought up. I think when you're communicating that bad news, the most important thing is find out what that patient already knows, okay? How much they know, what they know. Let them, we respond to their feelings. We let them guide us, and we are there to be present. And it can be very difficult. It's probably one of the hardest things to do. But I think for most people in life, it's not knowing is scarier than knowing. And to know that they have choices. So families don't understand advanced directives still, even to this day. I'm my mother's power of attorney for health care. Well, as long as your parent is their own person, they can make the decision, and that daughter has no legal control. In this community and around, we call it advanced directives before crisis. We want it declared. We want it out on paper. And I have examples of out there. Durable power of attorney is usually for the medical and health care. Sometimes they'll designate one child for medical, one for finance. You should have yours done no matter how old you are because you don't know what's going to happen tomorrow. A living will is maybe you don't have anyone identified for you, but it at least is a declaration to those healthcare providers. Maybe somebody doesn't have family, and at least they can put down what they want. Knowing if someone wants to be a do not resuscitate order, and this can be very difficult when someone wants to be a full code. They have a chronic illness that they're not going to survive from and probably won't survive the code, but we still have to respect their wishes, and that can be very difficult. We have things called 5 wishes, and we also need physicians' orders for life-sustaining treatment or ending it. We have different levels of care, and what most of us are used to is the acute care or curative care, and that's what we see. People come to the emergency room because they want to be treated. Palliative care is more when you have a chronic illness and you don't have per se a limited life limiting expectancy, a year, maybe 2 years, but the focus is still on comfort. Some palliation means comfort, where hospice care is you are deemed to be at 6 months of life or less if your disease follows its usual course. And there are actual Medicare guidelines that it's kind of like a checklist. If you meet X, Y, and Z, this is where you're at. For example, in cardiology, we look at the ejection fraction, that ability of that left ventricle to pump. And when it drops below 15%, your life expectancy drops dramatically. The biggest thing is that person needs to be involved in that end-of-life choice. So with hospice, one of the misconceptions is they think that the person is going to move in with them, and hospice isn't about that. They're available 24/7 for questions, symptom management, but we don't move in. It is an interdisciplinary approach, from everything from pastoral to dietitian to a nurse to the doctor, social work. It allows for symptom management to be done in the short term in the hospital. We offer medical supplies. You have to be careful though, because there are profit and non-profit hospices out there. And one of the things, if you're Medicare certified with hospice, is we follow up with that family for 13 months after the patient dies. And I think that's the coolest thing, and it's whoever from that family needs support. And it's free. Many insurance companies will negotiate for a hospice benefit under a home health benefit, but majority of hospice is done just because of the age under Medicare and Medicaid guidelines. Really, we focus on the symptoms. It is about symptom management, and it is mind, body, and spirit. I am going to put out there some really cool guideline from the American Cancer Society that talks on some of the symptom management that we do. Excuse me. There's actual certifications to be hospice certified, and what that really means is that you are a symptom management expert and have strong communication skills and can meet those families. And again, it is very mind, spirit, and body. As I stated in other little mini lectures here, that we've actually had to increase the morphine pump due to spiritual symptoms that were manifesting itself in physical pain, because this person, as death was approaching, had some unfinished business, whoever their higher being was, and was becoming scared and restless. And it was for us to work with them to just awful. And but we medicated appropriately. Caregiver issues, compassion fatigue. You look at what some of these caregivers have gone through. They're caring for these people in the chronic phase and in the terminal phase, and they're tired. For some of these families, it's a 24/7 job, and they're exhausted, and we need to be there for them too. Really, it is on a peaceful or good death. We do a lot of life review, try to bring family back together that maybe haven't connected. And that can be hard because that person, when we meet them, is not the way they were as a parent. So you got to be careful with that, um, and respect where that family member is. They may still be angry and never get over it. Giving people time to say goodbye, dying quietly, peacefully. Hospice is not about making death come quicker. It's about symptom management and peace. Postmortem care. What we will need to do then is in nursing homes, um, understanding the regulations of how we pronounce death. Um, Physical care of the body is where culture comes in. Some cultures want to bathe at the time of death as a family. Some want beautiful garbs put on. Some cultures want the body brought out facing Mecca. And again, it's just being, what are their needs and can we do it? So again, as death approaches, um, we are there for the patient and family. And another thing is working with the elderly and having a lot of loss when they die. We also have to learn to take care of ourselves so we don't burn out. Even though it's a natural part of life, it's hard when they tug at your little heartstrings and you continually lose people that you've been connected to.